Welcome to the Pivotal Podcast. Today we're joined by Dr. Yuri Quintana, Chief of the Division of Clinical Informatics at Beth Israel Deaconess Medical Center and Harvard Medical School. In this episode, we'll explore Dr. Quintana's career journey, his contributions to health informatics, his role in leading innovative projects, and his insights into the evolving landscape of health technology. Dr. Quintana, thank you so much for joining me today.
Oh, you're very welcome.
Yeah, I'm really excited about our conversation. So let's dive in. First off, tell me about the work that you're doing right now.
So I lead an academic division at Beth Israel Deaconess Medical Center, Division of Clinical Informatics, and we are a Harvard Medical School teaching affiliate. We've been here for about 50 years, and I've been here for just over the last 10 years. And we develop systems, evaluate them, and share those results globally. And the idea of medical informatics is really to find optimal ways of bringing the right information to the right person, whether it's a doctor, nurse, or patient or family member, so they can make the very best decisions and achieve the best health outcomes. We do that through innovations in technology, process, and we're very dedicated to understanding why things work or don't work and sharing those learnings.
Yeah, that's awesome. What do you love about what you do?
I think seeing the impact of what I do with not only the patients but families, and I think healthcare is very complex, and it affects not only the patients but those families. So being able to connect people and solve complex problems and seeing the impact of that work and making people's lives better, I think is really rewarding.
Yeah, absolutely. It's definitely a very tangible impact there for sure. What about anything you don't love? What do you wish were different?
Well, I think it's sort of a two sides of the same coin. I think I like complex problems, and that's challenging, and that keeps me interested in and committed to the work. But also the complexity of it makes it sometimes extremely difficult to make progress quickly. There's so many moving parts, and it's a very fragmented healthcare system. And so you need to be very resilient. So there are days when you get a little frustrated that things haven't progressed farther than you have. But change takes time when a problem is very large and very complex. So it's the same thing that draws me to be interested in this area as some of the things that makes me need to be patient and resilient.
Yeah, absolutely. So tell me about your early experiences, your educational background. What led you to health informatics?
So I'm an engineer, computer engineer, and was trained at the University of Waterloo in Canada. I was working on the early search engines that used AI to connect people to the best information. So intelligent search, intelligent filtering. And right at the time I started my career as a faculty member, the person that hired me, the dean, got sick with cancer. And she said, can you help my oncologist build a website to educate women about cancer? And so I thought, well, okay, maybe I'll spend a day a week for the first month or so helping this doctor. And this doctor had just joined a research network to help improve connecting doctors to the latest evidence so they can give the best treatments. So he invited me to a meeting, and it was an evidence-based network. I didn't actually quite know what the phrase evidence-based medicine meant. So these doctors explained it, and it's generating the latest evidence from scientific findings. And I thought, well, how hard could that be? We just implement some better search tools, disseminate it through email and websites. I'll dedicate, a couple of months to this and solve this problem and move on to other problems. And as I started meeting with doctors and other people, I started realizing how complex the healthcare system was, that there's really no one communication channel to doctors for education or even their supporting staff, and that any treatment requires coordination of care by lots of different stakeholders. And so this network that was well funded for about 7 years tried probably over 100 projects with 100 different people across the country. I was one of the lead investigators, but we had minimal impact, and it was humbling because each time we learned just how difficult things were, and I became more challenged to sort of figure out a proper solution. And so gradually, what was 1 day a week became 2 days a week, and eventually, most of my time was dedicated to health informatics projects. And eventually, that led me to work at different hospitals, move to other institutions, and solve problems. So I think the complexity of it intrigued me. I was actually quite surprised how hard the problems are. Um, but at the same time, it can be very frustrating. So you definitely have to be very innovative and think long term to be successful in this arena.
Yeah, absolutely. I imagine that even if a project doesn't have the overall outcome that you're looking for when you start it, if you can, I don't know, I just feel like it would be helpful to set like small wins along the way to set yourself up to feel like you're making progress and achieving success, especially for something that takes like 7 years that you're working on and still doesn't even have the outcome that you hoped, right?
Yeah, absolutely. I think developing roadmaps with goals, and what I've learned over time is that by bringing multiple stakeholders together, you sometimes start to realize that the problems you should be solving aren't the highest priority problems. And so that co-design approach allows you to start figuring out what's more important to work on and what is actually measurable. So I think that's early on in my career. I was mentored by people from Canada who helped develop the evidence-based community with people like David Sackett, Jochen Moore, and Brian Haynes, George Broman, and Alex Haddad. They're all sort of champions of evidence-based medicine. And through them, I met people here at Harvard, Charlie Safran and Warner Slack and Howard Bleich, who had been in the space trying to solve problems, but in a very patient-centric way, and trying to understand the problems from the patient's and family's point of view. And that friendship, which I met early on in my career through, they were invited to give talks in Canada, continued to this date, and eventually I ended up at Harvard in the division of these early mentors.
Yeah, absolutely. So for anybody listening who doesn't know, tell me about what you mean by evidence-based approach or evidence-based medicine and how that's different from maybe a standard approach.
So the evidence-based medicine approach tries to look at the scientific evidence that has been accumulated on testing different interventions in rigorous ways through observational studies, through randomized control trials, but really trying to measure clearly an objective and trying to evaluate the quality of those studies, because not all studies have the same level of rigor. So the evidence-based approach looks at all the studies, evaluates the rigor of them, and creates a computational way of sort of coming up with computing a level of confidence to know whether a certain type of intervention works or doesn't work, and in what context does it work. And so that's good science, and that's good medicine. But the evidence alone isn't enough to change, because then once you have the evidence, then you have to develop guidelines for how to bring that into practice. And those guidelines will differ depending on the resources that you have at your hospital. And so what works at a large academic medical center that has a lot of staff may not work at a community-based hospital. So apart from generating the scientific evidence through systematic reviews and meta-analysis, that implementation phase of creating the clinical practice guideline, the adaptation of that, and seeing how to operationalize becomes super important to be successful. And so that area has grown into something known as implementation science or learning health systems. And it's still very much a work in progress because every region, every environment has different capabilities and abilities and things that they're missing. And so after leaving Canada, I went to a hospital in Memphis, Tennessee called St. Jude Children's Research Hospital, where I helped develop platforms and tools and technologies, but also processes to help different countries adapt the latest evidence in pediatric oncology to local needs. So those clinical practice guidelines were adapted in collaboration with the people who both generate the evidence, but equally and more importantly, the people who are in these hospitals, to figure out how do you implement that into different regions, into different environments. And so now that I've moved back to Harvard, I'm working on similar initiatives now in other diseases. But that's sort of the concept of the learning health system, is how do you not only generate the evidence, but translate that into practice and contextualize solutions and learn from every type of implementation. And that's very much a national goal. It's a goal of many countries to sort of create these learning health systems that learn. And it's very challenging because you have to figure out to learn, you have to collect the right data and know how to analyze it. And so that's sort of the work that I and many others are trying to do now, how to build a true functional learning health system.
Yeah, tell me more about that. What do you mean by a learning health system?
So many years ago, almost 2 decades, there was a group called the Institute of Medicine in the United States, a leading think tank of top people in medicine, who discovered, among other things, that the third leading cause of death in the United States is preventable errors. They discovered that a lot of the latest evidence wasn't being put into practice, and that we had a lot of fragmentation and poor communication. So through a series of reports, Crossing the Quality Chasm, and other reports, including one that was called actually Learning Health Systems, they sort of identified the need to not only generate evidence, but develop ways to translate that into practice and collect intentionally the right data to learn from those implementations and iterate on those processes. And so that came out over a decade ago, the Learning Health Systems reports. And ever since then, several groups have been trying to build these types of learning communities. And I've had the fortune to build some of these and learn from them. And each time you go to build a new one, you sort of incorporate what you learned from before to be able to do that. But for example, cancer is an incredibly complex disease that requires teamwork. If you're fortunate enough, you may have a cancer that can be treated locally. But if you don't, then you might need to go to another more advanced center to be able to get treated. And then after you're treated there, you most likely want to return back to your local community hospital to continue your treatment there. That whole process of how we coordinate care across centers is still very much a work in progress. How do you know when to transfer someone to another center? What information do you transfer? How do you make sure you transfer them back with the right information so they can be cared at home? And not everyone can be treated at the most advanced centers. And it's also the most expensive place. So how do we do distributed care for cancer and other complex diseases in a timely, cost-efficient way, in a way that also approaches what patients want and what patients want is ideally to be treated locally. But if the treatments aren't there, to know when to be able to be treated at a more advanced center. And so that's sort of one of the major projects I'm working now, is within the New England area. How do we connect our cancer centers and collect data in a consistent way? How do we communicate when we transfer patients the data in a more efficient way? And not only help the healthcare providers, but how do we help communicate to the patients where they are in their journey, what their options are, and understand the risks and benefits of treatments at different places, both locally and elsewhere. So that's sort of trying to create some of those connections between siloed institutions is sort of the focus of my work.
Yeah. So what sort of role does informatics play in making that a reality? And also, like when you talk about learning health systems, what kind of timeline, like what? Let me think about this. I guess how like what's the recency on the information that system should be learning from?
It's a great question. So, the typically to create a learning health systems takes anywhere from 3 to 10 years because you have to sort of get people who want to collaborate first, and that's not easy. You have to figure out what are the problems that are the most uh, urgent for that community to work on. So just coming to an agreement on what are the key problems, and words matter. And so what quality means to one group might be very different. What quality care means to another group, what it means to patients. So it's about the communities getting to know each other, getting to know what is important to them, what they mean by certain terms, and then looking at what data is being collected and what data isn't being collected. When it gets down to that level, you start to realize that maybe how certain data has been encoded is reflective of how they view the data, and they may not classify things with a certain level of granularity that you might need for more advanced treatments. And you may not, for example, always collect some information that might be useful. So, for example, social determinants of health, people's income level, education level is kind of important. Things such as loneliness. Loneliness has been, there's a validated scale, several of them actually, to measure loneliness, and it's been correlated with poorer outcomes. So you need a social support network to get through some of these complex cases. And if nobody's asking, who's in your social support network and trying to get them additional help, they may not succeed and may drop out of treatments. And so one of the approaches you want to do in medical informatics is be very systematic about what are the questions that you want to ask, what data you need, what analytical methods you need to answer those questions, and then how does that information actually get into the database in a timely way. You mentioned about the timeliness. That is actually another very key component because decisions have to be made fairly quickly because the disease is progressing very quickly. So up to now, many of the cancer disease registries take many months or a year or more to update in terms of what are outcomes, and their high level outcomes are not specific to the patient or detailed. And so one of the things we're trying to build is a cancer health information exchange that allows you to exchange the data between centers with the consent of the patients in the institution, but in more real time, and to be able to transfer that data, the right data in the right format, so you can help someone in real time. And so many of the people across the country that are part of health information exchanges lament that the data is either incomplete or it takes too long to curate and get to there. And so it's not actually useful for real-time care. You can do some retrospective analysis on trends, but it's not impacting. And so even some basic things such as what medications you're on is really important because you want to make sure that new drugs don't have drug-drug interactions with your existing drugs. And so you have to, every time you meet with a patient, you do something called a medication reconciliation to update the list of the medications. And that's sometimes hard because the patient doesn't remember all the medications that they were on or things that they bought over the counter. And so how do we connect the databases of different hospitals, the pharmacies as well, to create a more central, more up-to-date medication history would be really useful, because then that would help people when they're trying to prescribe new care to make sure that those new drugs don't interfere or have adverse reaction. So the accuracy of the data is important, the granularity, how the data is documented, but the timeliness is also super critical to be able to do it. And that's all within the sphere of medical informatics. It's getting the right information in the right format to the right person at the right time to make the best decision.
That's so relevant, and I can see even from a personal example of how challenging that can be. So even just this past weekend, I took my youngest son, who's 3, and was having like a skin issue basically going on. And they found out. I took him to like an after hours care, right? And the doctor diagnosed him with this like bacterial infection basically, and then wanted to prescribe antibiotics, and then looking in his chart saw that he had had a negative reaction to a certain antibiotic before, right? So then she started asking me, well, has he ever tried this antibiotic? And it wasn't one that I'd recalled hearing of before, or reading a label and giving to him. But I've got 3 kids that are young, and they're in school, and they get sick a fair bit, as kids do. So I can't remember if he's had that before, right? And then I don't know, it was just kind of astounding to me, like as a parent of a patient, that hey, we don't just have this information on hand. It's almost like as the consumer of healthcare, it's like, well, you're the doctor, can't you see in front of him right there? Like, and I understand there are different systems that have to talk to one another, right? But from the patient experience side, it's like that seems like a pretty simple question, but not when you're talking about patients, like not even remembering what they're on. It's not even like the 90-year-old patient that's got a bunch of different medicines. It's like, this is a pretty simple, straightforward question, and I should be at my cognitive peak roughly right now at this stage in life, maybe. And I don't know. So we're doing like the best guess possible for his care, which is not what I would think is the optimal thing that we could be doing.
Yeah, absolutely. In this day and age with computers and technology, having to rely on memory is really kind of ridiculous, that we really should be farther ahead. But part of the problem is that we built a lot of incompatible systems that are owned by different groups and organizations. And the cost and planning for that interconnection has been historically underfunded and under prioritized. And so, and it goes much deeper than even just knowing the name of the drug, because drugs can come in different form factors, tablet, liquid, powder, and they can have different dosages. And some names are very similar. And the active ingredient may also differ from country to country. So say if you were to go to Europe and you need to get a prescription refill, you want to make sure you're getting the same medication. And even though the drug may have the same name, in 2 different countries, the active ingredient may be at a higher concentration in one country than another. It's rare, but it does occur. And so the pharmacists have to be very careful to make sure that you're getting the right medication at the right dosage levels. And some people do better on some form factors or another. And so currently, the dose representation, how you represent dose, is inconsistent among countries. There is a proposal to have a unique identifier for each medication that would be worldwide. And so that's the IDMP standard for the International Drug Medicinal Product Identifier. And it's been in the works for over 10 years. And the countries can't quite seem to agree on exactly the format it is. And they can't agree on when they are actually going to do the work of mapping all their existing drugs to this international standard. So it's not an impossible thing to do. A lot of people have thought of how to do that. There's lots of documentation. People generally say that's be a good idea to have. But it's been a long term coming. So I just finished a project for the last 4 years with the European Medicine European Medicine Agency and the European Union who funded this project. And we mapped the drugs between 3 different European countries, and our team mapped the American drugs, some American drugs, to the European drugs, and we sort of describe what are the differences in how the drugs are identified and how the drug dosages form. Now, it was just a pilot project to demonstrate the proof of principle. We have over 10 to 20 times more the number of medications in the US than in Europe. We have an incredible variety of drugs and forms and form factors. So part of the reason might be that people don't want to spend the money to convert and map all of the existing drugs to a single universal. But because we haven't done that work, it is very difficult to people know exactly what you were on if you just tell them just the name, right? Because they'll need to know not only the name, but the concentration, the form factor, the dose factors. And so all of that could be represented digitally very accurately. And it should be accessible, and it's currently not. And so what we want to do is, one of the projects is to sort of take that pilot project and expand it and beyond the initial set of drugs that we tested it. And so if you wanted to do a study of adverse reactions to certain medications, say within cancer, right? Say you pick 100 of the most common drugs in cancer, and you wanted to study the adverse reactions, and you want to study people in the US, Canada, France, and England, right now it'd be super hard to do because you would have to map all those drugs in each country and do the detailed work. But we could do that with a more standardized representation and cross-indexing. So these are some of the problems that are sort of hindering our progress. It's one that there's informatics methods to do that, but it requires also sort of political will to prioritize it. And just last thing I'll say about this is the drug interaction adverse events cause a huge number of problems in our healthcare system. Many people have adverse reactions. Some of those people end up in the emergency room, which costs time and money. Some of those people expire and pass away from adverse reactions. So it's estimated, and this has been done in multiple studies, that about half of the population doesn't take medications as prescribed. And the cost of adverse reactions is in the billions of dollars. And so it's a problem that hasn't been addressed and prioritized. And it's costing money, it's costing lives, and it's costing frustration, because anyone who tries to understand their medications has a real tough time understanding, because by law, each drug is supposed to come with an insert that describes the medication. By law, it can't be any less than 10-point font. Ridiculously, all the companies put it in 10-point font, so it fits in one gigantic piece of paper. And so another project we're doing is trying to help patients understand that medication label through a mobile app that helps you read it at a font you can read. And we're adding new technologies such as a chatbot where you'll be able to ask questions, what does this mean if there's a drug-drug interaction? So we have a lot of work to do before we have even just better identification of drugs and better communication of drugs. And that's just one element of the overall healthcare system. So there are a ton of projects and problems that need to be solved. And this is sort of what I was mentioning, like, you got to be resilient, pick your battles, and then try to move the goalpost forward and where you can.
Yeah. Oh man, mentioning a chatbot there, the whole time you were talking about that, I thought, that sounds like a problem that we should be able to solve with AI in some capacity. You'd think it would be good at comparing things and then saying, okay, here, this A equals B from this country to this country.
Right. So the mapping of the drugs, because there are hundreds of thousands of drugs worldwide, would require coordination by many governments and companies. Now, Interestingly, the companies that I've spoken to who produce medicinal products, the drug and pharma company, are very interested in solving this problem. So, but there isn't universal consensus to move forward. The government would have to sort of approve. We actually approve and prioritize that work and fund the work. We hosted a webinar on the IDMP challenge and what the roadmap was. And so I'm hopeful that the more we raise awareness of this, there'll be more interest to fund and move this forward, because it's critical. And I can tell you, I was once at a hospital. You probably remember when Katrina happened in New Orleans. Was everyone evacuated Katrina very quickly, right? Because the storm changed directions, and people. I was scheduled to go to a conference in New Orleans that week, and I was about to get on a plane when they said the plane is canceled. Everyone's been told to evacuate. Well, as people evacuated, the hospital staff and the patients also started to evacuate quickly. And there was no cloud-based backup of the medical records. And so cancer patients ended up showing up at other hospitals, and they needed ongoing care. And so they would arrive and people would ask, well, what medications are you on? And some patients are on a lot of medications. Not everyone could remember all of those medications. So that was an example where having a cloud-based solution, unique identifiers available, or even allowing patients to have an app that allows them to stay current with all their medications would have been really useful. So fast forward to today, we have cloud-based storage, but we don't have really good mechanisms for patients to download that into their local apps. You have the legal right to request it. You may get reams and reams of paper, PDFs, but then entering that into your app is a real chore. We still have the problem of forest fires and other things that causes people to evacuate quickly. So the same problem that happened during Katrina could happen again with future hurricanes and other environmental disasters. So this is sort of a problem that is still unsolved, the ability to sort of give people real-time access to their data in a way that you can actually use. And in some cases, it's a case of life and death, right? If you suddenly evacuate. The number of storms we're getting is increasing. The number of forest fires is increasing. So it's a disaster waiting to happen again. And so I'm pretty motivated to try to solve this. It really broke my heart to see all these families trying to figure out how to continue care safely. Hopefully the things that we're working on will contribute to a solution in that space.
It's amazing because I feel like I'm hearing a theme here, whether we're talking about countries or pharmaceutical companies or healthcare organizations, that they're all siloed. So I'm just imagining all of these different silos, all these different buildings, and they've all got, their way of doing things. But they know there's a need for them to be able to communicate, right? But then it comes down to probably time and money and saying like, hey, whose responsibility is it to build the bridge here so that we can communicate, right? Because if there's a cost, well, who's going to be benefiting from that in a way that maybe they can recoup some of that cost? It seems like that would be a very challenging problem to solve because of that.
Yeah, absolutely. And so this is sort of the problem of our fragmented healthcare system, that it is funded in a piecemeal way. So you go to do a doctor's visit. They charge you for that visit, for the time that you spent with that provider. If you order lab tests, you pay the company for the lab tests. And then if you order medications, you pay for the medications. But no one is paying, right, for that extra work of connectivity across different centers. So there have been some sporadic investments to create some sort of cross-institutional networking. So over a decade ago, there was some funding for health information exchanges, which created a bunch of different exchanges across hospitals within a region or a state. The problem for most of them is that they've had difficulty finding sustaining funding to do that. Some of them have obtained funding through their hospitals, but the hospitals have a trouble finding where do you get the revenue for that, right? Because you can't just bill the insurance company, hey, we're going to spend $10 million supporting the local health information exchange, right? There's no billing code for that. And so we have a real problem with trying to figure out how to fund the learning healthcare system. But if we don't, we spend many billions of dollars more in adverse events, poor continuity of care, or when patients have to move from one system to another. Say you change jobs, all your data is in hospitals that were part of your previous health insurance coverage. Now you move cities, or even you switch job in the same city, you're now part of another health insurance company that's maybe connected to other hospitals. And so that data is siloed in these others. So there are some standards for data extraction, but there's still a cost to extracting that data and importing it somewhere else electronically. And so even though we legally, as patients and individuals, have the right to ask for our data, you typically get that data as sort of a gigantic set of PDFs with, not a very good way of sort of managing that data. So there's a lot of work to be done to truly make this interoperable.
It's interesting, and I wonder because, okay, you talk about it being so fragmented, right? But how providers are being paid for services, right? So it's paid for the visits and the time and these different things. And I wonder how difficult it would be to integrate into that system some sort of payment for the exchange maybe that facilitated the delivery of the information that was needed for that visit to occur. And so I don't know if initially I was thinking, if you paid the facility that sent the information, there would be incentive there, but that's just information, or it seems like, okay, well, that still doesn't incentivize them to take the time out of what they're doing, providing care to build something. But if you were paying exchanges to facilitate that transfer of information and they got paid every single time information got exchanged, then one organization, one health exchange or health information exchange, right, seems like it would have that incentive to, hey, let's build something that's really effective. Because if they got, I don't know if it would just be based on the exchange of the information, but also like the quality of the information, if there was a scale for that. And maybe that's already being done. I don't know.
So, there's a cost to everything that you mentioned before. And the problem is, where does the revenue initially come from, right? So if you pass that on to the hospitals, where do the hospitals generate the revenue to do that? And so there have been some attempts to sort of group services together and group patients together. So there is a model called accountable care organizations, where you are being paid a lump sum of money to care for, say, 10,000 patients. And they estimate what the average cost will be based on predicted number of people who will have diabetes, cardiovascular disease, or cancer. And so you calculate the total value and give a lump sum every year for that 10,000. Part of the problem with those models is that the actual amount that is calculated isn't always accurate. And so your costs sometimes are much more than what you're given. And so not everyone's all that keen about being part of an ACO if there's just too much risk that you may not actually get paid for that amount. So the AC model hasn't really grown as fast as people initially thought. It also sort of assumes that you're going to do some due diligence to try to prevent disease. And as a nation, we haven't actually put a whole lot of priority in implementing prevention. So there's been academic studies on how to do that, say, improve healthier living styles, right? More exercise, better nutrition, less smoking, less alcohol consumption, right? So that it lowers your risk for other conditions. Well, programs have had limited impact and haven't been particularly scaled, and they have to be tailored to individuals because everyone's circumstance is different. So what motivates you might be different than what motivates your neighbor to change their lifestyle behavior. And so we don't really have scalable public health, disease prevention programs that have really been scaled very well. And so, if that lump sum of money, some of that was used for prevention, and if those things were actually scalable and effective, and it actually reduced your overall cost, and then you'd have a certain profit margin that you can then use to better fund your health information exchange, that might work. But we don't really have very scalable public health systems. The savings almost never happen. And even if there is savings, it's not necessarily the case that that money is going to go to interoperability. So it's kind of a super complicated scenario. But ultimately, we actually have to prioritize the need for infrastructure and better informatics, just like the way we have implemented better ways for having roads, that are standardized width, the way we standardize railroad tracks to be a standardized width, the way we standardize how financial transactions are done and audited. And standards are evolving. The problem is to implement those two problems. One, there's too many competing standards, which means that it's not really a standard if there's 13 different standards and people are using different standards, right? There are 13 proposed standards, but not a commonly used standard. That's problem one. Problem number two is that there's a cost to implementing all of this, and that needs to be covered. And so at some point, a combination of government and private sector funding has to come together to agree on fewer standards that are implemented more thoroughly, scaled more thoroughly, and are put to work. And so that's sort of what we're doing now with cancer. We're looking at all the different models that there are for storing cancer data. We're trying to decide which ones narrow the field down to a fewer number of data models, and saying, can we all agree just to use these fewer data models? And can we figure out how to link the data between our cancer centers? And it's not only a problem between cancer centers, even within a cancer center, it's a giant universe in there of different databases and different groups. And so we're going to try to help groups within a large enterprise agree on some common internal standards that hopefully will align with what our neighboring cancer centers are doing, so that we could connect the dots between our data. So that's sort of the roadmap that we've gone. And we've created something called the DCI network.
I was just going to ask about that because I'm like, here we're talking about these problems and things not being scalable. And I'm like, wait, you're working on something for that.
Yeah, so the DCI network is an action tank. It's more than just a think tank. So we don't just want to get together and talk about problems. We're bringing people together to talk about these scalable problems and to propose what are some common scalable approaches to doing it. What's the data model? How do we link the data? How do we have some common ways of evaluating success and measuring progress? And so it's building the learning health system in a collaborative way across the centers. And so we have different academics and healthcare providers are part of the networks. A central part of this is patients and family caregivers to sort of center on what's priority for them. We've got some private sector companies that develop technologies, or life sciences companies that develop that. And we invite people from government agencies to come to our events and give their opinion of where the government's, what they're thinking about, and give them feedback on what we're thinking about. So we've had the great pleasure to have the FDA come to our previous two conferences. So they've sent some senior people. They've told us what they're working on. We've told them what we're working on, and we're trying to find synergies to do that. But the collaboration has to happen in all directions, right? It can't be just two companies or two centers. It can't be just academics and private sector. We have to have people at the table. Otherwise, we end up with, instead of 13 standards, 26 standards and evolving. So hopefully we'll we'll come up with some consensus architectures and databases. And then the proof is in sort of the building of these systems, right? Once we build them, we'll see whether we can actually transfer data in a timely way in the granular level that we need, and we can get success. And hopefully we'll do that all before more people need this critical service. Because right now, if you are in this process, it is very challenging for your providers to sort of share the data in a timely way. I mean, they're doing it, but sort of through PDFs, faxes. Believe it or not, faxes are still widely used, in part because some outdated legislation that some people, initially the fax was considered to be secure. And, it's only secure from machine to machine, but anyone walking by the fax machine can grab that piece of paper. So unfortunately, a lot of data is still being shared through faxes. But what we need is better electronic ways in the right format that we can parse it and put it into the right databases with the right security checks and get that data in a timely way.
Yeah, that makes sense. And really quickly, just for anybody listening who didn't catch it earlier, remind us, what does DCI stand for?
So DCI is Division of Clinical Informatics. That's the name of our division. And the division has gone through a couple of different name changes. It was called Computer Medicine. It was also then earlier called the Center for Clinical Computing. At some point, we changed it to Division of Clinical Informatics. The field of informatics has evolved with different names. And so there's biomedical informatics, which is broader. There's public health informatics, consumer health informatics. And for us, our division, DCI stands for Division of Clinical Informatics. DCI really looks at the entire spectrum of healthcare and data. So we're not just about studying what happens at the hospital. We're more holistic about what's happening across the ecosystem. And so DCI Network is an outgrowth started by people at DCI. We previously hosted some very successful joint conferences on public policy and patient privacy, which helps shape and improve some of the patient privacy policies that there are in Europe. So we've done these sort of collaborative forums before. So DCI Network is the latest sort of action-oriented consortium that we host, and we organize conferences. There are for organizations that join, there's a subscription fee that helps us cover the costs of events and sort of organizing these blueprint architectures. We've got now some funding to actually build the first chatbot, and we're going to figure out how to test that chatbot to make sure that it not only answers proper answers during the trial, but then how do you monitor chatbots over the long term to make sure it doesn't, over time, degrade and start giving wrong answers. So that's sort of a big challenge because AI is sort of somewhat unpredictable. It learns from its interactions, but it doesn't always learn properly. And so you have something called AI model degradation, that over time it actually starts giving wrong answers. So that's those are our two main projects right now: the linking of cancer databases and the building of this chatbot. Ultimately, what we want to do is connect those two so that while people are using these chatbots, if they want to contribute their data on how they manage their symptoms, they can contribute it to a research database, and we can learn over time how people have managed their condition and their symptoms over the long haul. So it's a longitudinal study of how patients have managed their disease, so we can learn how to care for patients better in the future.
Yeah, that's amazing. Dr. Quintana, if people wanted to learn more about DCI Network, where could they go to find out that information?
So there's a website called dcinetwork.org. You can go there. Almost all of our content is free. The part that isn't free is some of the working groups that are sort of developing these pilot projects. Some of that stuff is still in development, so it's not polished, it's not been vetted or approved. So that is sort of in a private group area until we publish. But we have probably over 100 webinars and courses. We had 3 major conferences. They're available online. And then if the organizations want to join as a member, have them, my email's there. And people can send me an email to figure out if they want to get involved with some of these projects. We welcome companies, nonprofits, and we're also open to having patients. Patients are an important part of that. So we have patients and patient advocates who are part of our network as well.
Yeah, that's great. And then if anybody wanted to learn about what else you were working on, is there another place they could go find out about that?
Yeah, so if you type in yuriquintana.com, it redirects to my Harvard website, which is a longer URL, but yuriquintana.com just sort of redirects you to the right place. You can find out there. I'm also on LinkedIn, so I post regularly what I'm working on there and with events, and we have links to the different events that we have done. So you can reach out to me through LinkedIn. Happy to connect with you. So that's another way as well. I'm on X, formerly Twitter. I occasionally post in there as well what's happening in our lab.
Perfect. Yeah, well, Dr. Quintana, thank you so much for being with us today and sharing your journey and your insights. It's been super interesting to hear about all the different aspects that go into analyzing the different challenges, right? Because they're so multifaceted. So I really appreciate hearing more about the work you're doing there and just the interesting things you're working on and the hope for where informatics can lead us in the future.
Great. No, my pleasure, Ben, and thank you for doing this podcast. I think it helps bring awareness of what this field is doing. I think it's a phenomenally exciting field that has real impact. And, there's no set way to get into this. Yes, you can get formally trained. If you're a physician, you get board certified in informatics. But our division has trained both nurses and pharmacists and pathologists. And we are actively engaged with training patients, and they're teaching us what we need to learn about how to develop these systems. So there are multiple ways to get into this field. You don't have to be a doctor or have a PhD. We need all kinds of people to be involved. So whether you're a doctor or a programmer, engineer, social scientist, or a patient advocate, or a policy person, there's all kinds of ways you can be involved in informatics. So I encourage you, people who are listening to this, who are interested, is to learn more about it and get involved in projects. I think most places want more diversity of different stakeholders contributing. So you can reach out to different groups and say, I'm interested in your project, I'd like to learn more. How can I contribute? Especially patients. I think we need to have more patients as part of the design of these projects and development of policy. And so I encourage, and I think we're all patients. We may not know it. No one is in perfect health. At some point you discover that you're in worse health than you thought. But at some point, all of us get sick. All of us have a family member that gets sick. And so if we can all work together to make the healthcare system better, then it'll be better when you or any other family member needs the system.
Absolutely. It's so true. I mean, literally, it's the thing, it's one of the few things that we can improve and all benefit from.
Yes, absolutely. Well, thank you, Ben, for doing this podcast. You have great content, and thank you for all you do to help the healthcare system better.
Yeah, absolutely. I appreciate it. It's a real pleasure. To our listeners, we'd love to hear your thoughts and experiences on this episode. You can share your comments on LinkedIn or directly on the podcast website at pivotal.buzzsprout.com. If you know somebody in healthcare or not in healthcare, just anyone at all who would find this episode inspiring or beneficial, please share it with them directly. And you can stay tuned for more episodes here on the Pivotal Podcast, where you can listen live on LinkedIn or anywhere you get your podcasts. Until next time.